Welcome everyone to today's talk on psoriatic arthritis. We're keeping it short and simple with just 12 slides to review. This session is specifically tailored for medical students and trainees who are new to rheumatology clinic rotations. Psoriatic arthritis is a bread and butter case you're likely to encounter during your rotation. So let's dive in and explore the essentials. Please note that this presentation will focus providing a simple and brief overview, not covering treatment details, as that I think warrants a whole new separate lecture. And due to copyright issues, no picture is included in this lecture. Did you know there are more than one type of psoriatic arthritis? When rotating through a rheumatology rotation, you might be asked about different patterns or subtypes of psoriatic arthritis. There are a total of 5 as denoted on the right side of the 2 columns here. First, there's the type that predominantly affects the DIP joints along with the nail changes. Secondly, arthritis mutilans here, but this type is not as commonly seen nowadays because hopefully patients receive appropriate treatment before reaching this stage. Third, there's oligoarthritis, meaning there will be a few asymmetric joints that are involved, and dactylitis or sausage digit may be categorized here. Fourth, the RA-like psoriatic arthritis will involve smaller and symmetric joints of hands and feet, almost representative of what you would expect to see in rheumatoid arthritis. Lastly, there's the axial subtype, which can involve the spine and the sacroiliac joints. Remember, it doesn't mean because a patient presents predominantly with one subtype that they will remain in that subtype. These subtypes are not mutually exclusive and may change over time. Let's quickly review some of the subtypes of psoriasis. Just like the joint involvement, psoriasis also comes in many different shapes and sizes, quite literally. Just to clarify, when I say psoriasis, I mean the skin disease. There are various subtypes of skin psoriasis. Some of them are described here on the left-hand side. First, the inverse kind, which will appear mainly in the intertriginous areas of the body, such as the armpits, under the breasts, groins, and so on. Palmoplantar type, as you can guess from the name, will appear on the hands and feet of the patients, and they could appear as red macules or pustules. Also, there's the guttate psoriasis, and patients with generalized pustular psoriasis will appear very sick with generalized symptoms like fever, chills, fatigue, weakness, and their rash will be very itchy. Erythrodermic rash involves most of the body surface area, like more than 90% of it. In this next slide, I have descriptions that match various subtypes of psoriasis and psoriatic arthritis. Some of the answers I already gave out from the last slide, so let's briefly go over them. Which subtype involves the intertriginous regions? That would be inverse psoriasis. How about strep infection-induced psoriasis? That would be guttate psoriasis. Do you remember the type of psoriasis associated with generalized symptoms? Yes, it's called generalized pustular psoriasis. The name suggests its association with systemic symptoms. What about the type that is associated with smoking? That would be palmoplantar psoriasis. These subtypes are all very interesting, but the most common subtype you'll see in clinic is plaque psoriasis. Now, let's discuss psoriatic arthritis. What is the most common type of psoriatic arthritis? That would be the oligoarthritis type. Then what would be the most classic type? Although oligoarthritis is the most common type, the most classic type described when learning about psoriatic arthritis is involvement of the distal, interphalangeal, or DIP joints with nail changes. One subtype of psoriatic arthritis that can be confusing to diagnose is polyarticular rheumatoid arthritis-like subtype. And let me explain why teasing out the two can be challenging for clinicians. Psoriatic arthritis is called seronegative arthritis due to the fact that in most cases, the rheumatoid factor will be negative. In fact, this is one of the classification criteria as known as CASPAR criteria for psoriatic arthritis. So patient who comes in with a high suspicion of psoriatic arthritis, you can give 1 point for them not having a positive rheumatoid factor. However, nothing is definite in medicine, and so some psoriatic arthritis patients will present with rheumatoid factor or even anti-CCP. If they present with, let's say, bilateral hand pain and feet pain and their rheumatoid factor or anti-CCP is positive, you could see why patients with psoriatic arthritis initially can be diagnosed with rheumatoid arthritis. To make matters more challenging, patients could actually have coexistent rheumatoid arthritis. Patients sometimes evolve to reveal their diagnosis down the road, but there are some clinical tips you can look for to help you distinguish the two diagnoses. One thing would be DIP involvement in psoriatic arthritis, which you not typically see in rheumatoid arthritis unless they have concomitant osteoarthritis with their rheumatoid arthritis. Next, let's talk about the timeline. In the majority of patients with psoriatic arthritis, psoriasis will develop first with a median time between the diagnosis of skin and joint disease, 7 to 8 years, an average of 8 to 10 years in about 70% of patients. In a small number of patients, arthritis may precede, although it's only a small portion of patients. About 15% of the times they can occur at the same time. So just to recap, about 70% will develop skin disease first, 15% will develop arthritis first, 15% will develop both skin disease and arthritis together. It's very interesting. The disease course for skin and joint for those who develop psoriatic arthritis seem to run an independent or separate course, meaning the severity of skin disease is not necessarily associated with severity of joint disease and vice versa. Plus, they will not always flare together necessarily, although it is possible. Okay, risk factors for psoriasis. What increases the risk? Alcohol, smoking, and stress increase the risk, whereas vigorous exercise and bariatric surgery will decrease the risk. You'll see the pattern here, but diabetes, metabolic syndromes are also risk factors for developing psoriasis. Taking vitamin D supplementation doesn't really increase or decrease the risk of developing psoriasis. Okay, physical exam. There are some of the findings you can expect to find or clues you want to carefully search for. First, let's start with the joints. Dactylitis, aka sausage digits, can be seen. When in doubt, compare the digit that looks swollen to the contralateral side, and you may be able to see the subtle difference. And also, the digit will feel tender between the joints when they have dactylitis. Dactylitis is often associated with erosive disease, and it gets you 1 point on CASPAR criteria. Next, DIP involvement. We discussed already, but one thing I will mention here is that patients with DIP involvement will have worse nail changes. The extensor tendon enthesis is next to the nail root. And what do I mean by enthesis or enthesitis? Enthesis, it just means that it's a site where the tendon or ligament attaches to the bone. So enthesitis just means that there's an inflammation at that attachment site. Examples of enthesis will be Achilles tendon attaching to the calcaneus bone, plantar fascia attaching to the calcaneus bone, or epicondyles will be another site you could look for on exam. Spine also have enthesis, so where the Sharpie fibers attach to the vertebral bodies, that's a potential site for enthesitis. So going back to the DIP involvement, when the enthesis of extensor tendons become inflamed, nail growth inevitably will be affected, as you can imagine. So people will have nail changes, including but not limited to hyperkeratosis, onycholysis, pitting, and so on. Some may consider enthesitis to be extra-articular, some may say it's periarticular, but semantics doesn't really matter. But you want to make sure to look for these things. So Achilles tendon areas, epicondyles over the knees. You could firmly palpate and feel for tenderness over the areas, but sometimes you may just be able to see the swelling. Tendinitis, which is periarticular, can also be seen, but this is not so easy to diagnose by physical exam alone. You may need to use the musculoskeletal ultrasound or MRI for diagnosis. Next, we have Koebner phenomenon. What is Koebner phenomenon? Simply put, it's the development of skin disease in sites of skin trauma. Patient who may have had an injury or trauma to a certain area of the body, let's say, and it doesn't necessarily have to be the skin injury. They may experience Koebner phenomena over that area. Patients who wear glasses is another example. They may develop Koebner phenomena due to the legs of their glasses rubbing against the skin. So you want to look behind the ears to check. But to clarify, even those who do not wear glasses, you want to look behind their ears because this is one of the common spots where psoriasis can be hiding. This brings us to the next point on our list, psoriasis. Sometimes patients will know and tell you exactly where they have psoriatic rash, but other times they may not present with any rash, although you have a high suspicion of psoriatic arthritis. Then you want to look for the rash in hidden places. The typical places they can hide would be umbilicus, scalp, behind the ears, perineum, intergluteal cleft. Also, make sure that they have their socks off because they can commonly present in the lower extremities. Nail changes. Only 30% of the patients with psoriasis, so skin disease, will have nail changes, whereas whopping 80% of psoriatic arthritis patients will have the nail changes. These can present as pitting, onycholysis, oil spot sign, hyperkeratosis, nail crumbling. And severity of nail disease will predict the arthritis, so it's important to check the nails of the patients. Let's talk about lab findings. So the lab findings in psoriatic arthritis are pretty non-specific. You can see elevated ESR and CRP and leukocytosis in less than 50% of the patients. And anemia may be present due to the chronic NSAIDs use. In terms of autoantibodies, although it is a seronegative arthritis, some of these autoantibodies like rheumatoid factor, ANA, and anti-CCP can be found. For ANA, by the way, generally you see low titer ANAs with low clinical significance. For example, you may see ANA positivity in more than half the patients, but in low titer of 1 to 40. HLA-B27 can be positive up to 25% of the patients. Next, we have imaging findings. Just like other inflammatory arthritis, you'll see erosions in patients with psoriatic arthritis, although initially it may not be radiographically evident. What are some of the unique characteristics of imaging findings of psoriatic arthritis? In med school, you may have heard things like pencil and cup deformity or osteolysis of bones when learning about psoriatic arthritis. These are referring to arthritis mutilans, but there are other radiographic changes too. Rather than listing them all here, I want to emphasize the point that the erosions in psoriatic arthritis can present with new bone formation, and this is very characteristic of psoriatic arthritis. So if you hear new bone formation with erosions and ankylosis of DIP, psoriatic arthritis should be on your radar. The distribution of changes will serve as a helpful guide. Like I mentioned earlier, erosions of the hands with asymmetric distribution affecting DIP joints, eccentric erosions with periostitis and bony ankylosis, and relative absence of periarticular osteopenia, and so on. Erosions can be seen at enthesial sites, and musculoskeletal ultrasounds may show signs of enthesitis and dactylitis. How about axial skeleton? Remember two things when it comes to axial skeleton: syndesmophytes and SI joints. The classic appearance of syndesmophytes of psoriatic arthritis is described as being large and non-marginal. You may also hear a term like jug handle appearance, opposed to syndesmophytes seen in ankylosing spondylitis, which will appear thin and marginal and symmetric. SI joint erosions will be also asymmetric for psoriatic arthritis, and this can be seen on the x-rays. Generally, when we discuss seronegative spondyloarthropathy, there are 4 diagnoses we're thinking about: psoriatic arthritis, reactive arthritis, IBD, or inflammatory bowel disease, or ankylosing spondylitis. When it comes to the axial skeleton changes of these conditions, it might be helpful to pair groups that have similar radiographic axial changes. To give you the answers, psoriatic arthritis and reactive arthritis present similarly, and IBD and ankylosing spondylitis present similarly. To keep the information straight in your head, don't memorize them all. Just memorize one group's appearance and remember the other group will present differently. This is what I mean. One way to keep the groups organized in your head is to remember, number one, there are 4 diseases in the category of seronegative spondyloarthropathies: psoriatic arthritis, reactive arthritis, IBD, and ankylosing spondylitis. Okay, I got that. Number 2, remember how psoriatic arthritis presents: asymmetric SI joint involvement, large and non-marginal syndesmophytes. Okay. Number 3, which other disease out of the 4 that we discussed has an abbreviation that looks like psoriatic arthritis? Reactive arthritis, with 3 letters with first and third letters in capital letters. Number 4, the other 2 seronegative spondyloarthropathies, IBD and ankylosing spondylitis, have opposite patterns. This way, all you need to remember is the pattern of psoriatic arthritis. If you still can't remember, imagine a patient with psoriasis on their skin drinking out of a large jug with asymmetric handle. Okay, hopefully that helps. CASPAR criteria. We already mentioned about CASPAR criteria, so I'll briefly go over this. There's a total of 5 criteria and you need 3 points. The criteria have a specificity of 98.7% and a sensitivity of 91.4%, although the values may change for people with axial skeleton dominant disease. To review each criterion, psoriasis is the only criterion that can give you 2 points at once. You can get 2 points if the patient has current episode of psoriatic skin or scalp disease as judged by a dermatologist or rheumatologist. Personal history of psoriasis according to the patient or doctor gets 1 point. Family history of psoriasis in a first or second degree relative gets 1 point. Typical nail dystrophy like onycholysis, pitting, hyperkeratosis during current physical exam gets you a point. Negative rheumatoid factor gets you a point, and any testing is accepted except latex with preference for ELISA or nephelometry. Dactylitis gets you a point, and it doesn't matter if it's current or just a history of it. However, a history of dactylitis has to be according to a rheumatologist, and it doesn't get a point if patient just tells you that his or her digit looked like a swollen sausage. Lastly, a radiographic evidence of juxta-articular new bone formation gets you a point. For your information, juxta-articular just means near a joint, so having new bone formation near a joint gets you a point. To be more specific, the CASPAR criteria says ill-defined ossification near joint margins on plain radiographs of hand or foot to be exact. And they're excluding osteophyte formation. So again, new bone formation becomes very specific for the psoriatic arthritis diagnosis. Last but not least, comorbid conditions. And there are many, but I have listed 4 biggies. Number 1, HIV. Number 2, heart disease. Number 3, anxiety and depression. Number 4, metabolic syndromes, hypertension, and diabetes. When someone presents with a sudden onset of psoriasis, remember to check HIV because it's a comorbid condition. And also think of checking HIV when the patient has trouble controlling the disease and the disease is refractory despite many treatments. Number 2, also psoriasis is associated with increased cardiac risk due to the fact that they have common inflammatory pathways. Number 3, mental disorders, especially anxiety and depression, occur more commonly among patients with psoriatic arthritis compared with those with psoriasis alone. Metabolic syndrome, diabetes, hypertension are also common comorbidities, and you can see why losing weight or vigorous exercise and bariatric surgeries have a positive impact on psoriasis. Okay, that's it for today, guys. Thanks for watching and good luck studying. See you next time. Bye-bye.